Good evening, everyone. Good afternoon, good morning, wherever you are in the world. Welcome to the September 2020 Food Thinkers. And it's wonderful to welcome you all this evening. It's great to see such numbers joining us for our Food Thinkers webinar. So my name is Professor Kieran Hawkes. I'm Director of the Centre for Food Policy at City University, and I'm delighted to be chairing this webinar this evening. It's our 2020-21 Food Thinkers seminar series, which brings together big ideas from women in academia, policy, business, and advocacy on redesigning food systems and on designing effective interventions, effective policies for changing what the world eats. And that's certainly what we're going to be hearing about this evening. I'm delighted to welcome Meena Daivadanam, who is a senior lecturer and associate professor at the Department of Food Studies, Nutrition and Dietetics at Uppsala University in Sweden, and affiliated to the Department of Global Public Health at Karolinska Institute and the International Maternal and Child Health Division at Department of Women's and Children's Health at Uppsala University. And Dr. Daivadanam brings a real expertise in the field of intervention and implementation research. She's a trained medical doctor and has a PhD in public health interventions. And her experience is all about working with dietary and also non-communicable disease interventions in particular in India, as well as interventions in Sweden, South Africa, and Uganda. And she works as well with evaluating and understanding food environments and the interactions between behavior and food environments. So a real stellar researcher. I'm a big fan of her work. Welcome to Food Thinkers. I wanted to just do a little bit of housekeeping. This webinar is being recorded and it will be available afterwards online on our YouTube channel. We are going to be inviting you to ask questions and answers this evening. We're going to ask you to use the question and answer feature, which should be at the bottom of your screen. It says Q&A. So if you want to ask a question, ask it at any time in the Q&A function. We will wait for Meena to finish before we come to them, but do feel free to add those in as you think of them. And if you do, we want most of all for you to listen and engage and ask questions. But if you do want to share what you're hearing with the outside world on Twitter, the hashtag is Food Thinkers and the handle is @FoodPolicyCity. And this is part of a series of Food Thinkers, as I mentioned earlier. And just to note that our next one will be Karina Millstone of Feedback Global on October 21st. If you do want to sign up for our mailing lists, for which you will receive information about these Food Thinkers, please put a note to the panelists in the chat with your name and email address, and we will add you to our mailing list. So with no further ado, I'd like to ask Meena to start your presentation on the subject of
Okay. So I thought in this seminar, it's good to kind of situate where my work is before going into the actual presentation. So I work mainly with design and implementation of complex health interventions, especially focusing on non-communicable diseases. And I've not worked with policy. So all these interventions that we really talk about are non-policy related interventions, mostly focusing on behaviors. What I think for this presentation is that I would like to focus on examples related to different phases of development of real life or real world interventions, as they're called. And since the focus is really on NCDs or non-communicable diseases and health and public health interventions, there are some inherent value judgments which are part of this of the presentation, which is especially when we talk about healthy versus unhealthy, we really mean when we talk about healthy, it's healthy foods, it's about increased consumption of fruits and vegetables, or moderate consumption of salt, sugar, oils. And we talk about healthy versus unhealthy in the scientific sense, not in terms of different perspectives. And also when we look at the efficacy to implementation pipeline, the intervention studies that I work with mainly fall within this red box. So we have, it's like the late stage effectiveness studies and early stage implementation studies. And I mainly focus on two different examples. So one is a pragmatic randomized controlled trial, which is called Behavioral Intervention for Diet, or BID, which was implemented in India. And that was a dietary intervention at the household level. And the second is an adaptive implementation trial called SMART2D. And this was an early implementation trial, specifically hybrid type 1. And this was implemented in Sweden, South Africa, and Uganda. And these are completely two different trials, but in terms of the examples, I kind of mix and match or go back and forth between the two, because a lot of the experiences are actually common from the different projects and the different sites. So just to introduce you briefly to the study settings. So the study in India is set in the South Indian state of Kerala, specifically in the capital city of Trivandrum, where we chose rural areas in one of the 4 revenue districts within this Trivandrum or Thiruvananthapuram district. And in SMART2D, we had 3 different study settings. We had Uganda, South Africa, and Sweden, and they were all chosen because they represented a specific income setting. And within all these countries, we also focused on either under-resourced or socioeconomically disadvantaged suburbs. So in Uganda, it was under-resourced rural areas. In South Africa, it was under-resourced urban townships. And in Sweden, it was socioeconomically disadvantaged suburbs with a higher proportion of immigrants. Now, the aim of the Kerala study was to look at a change in household behaviors for specifically relating to fruit and vegetable intake, fruit and vegetable procurement, and consumption of salt, sugar, and oil. And the focus here was on primary prevention because the target population was really healthy individuals with no prior history of chronic diseases. And in SMART2D, the aim of the study was to evaluate the added benefit of a community component for provision of self-management support in type 2 diabetes. And here it was both primary and secondary prevention, where we had both individuals who were either at high risk or had pre-diabetes, or individuals with diagnosed diabetes. So both of these projects, as I said earlier, were different, and one was a dietary intervention and the other was really focused on self-management support for type 2 diabetes. Now to go into to put this talk into perspective, I thought it was good to talk about the fit of the intervention with the context and the population. And if we go from the left-hand side, the left-hand side, the figure is inspired from the knowledge to action framework. And in the center, you have the evidence or the knowledge and the different aspects, and looks at how this can be translated into action, which is actually the outer circle, which has the intervention and the processes. And on the right-hand side, we have the individuals who are within their context. And you have, according to the consolidated framework for implementation research, context is often described as inner setting and outer setting, where the inner setting, you have features that will influence implementation but are closer to the target population. So for example, if it is a healthcare intervention, it could be leadership. And in this case, if it is a dietary intervention at the household level, it could be the household. And then you have the outer setting where it's mostly external environments, like, for example, policy or incentives. And I guess it's kind of easy to see that when we develop the intervention, it becomes important that not only does the intervention be relevant for the target population and the context, but that the intervention is actually built on and together with the individuals, and taking into account the features of the context that we're looking at. So finally, it's really, so the idea is to think about what is the fit of different aspects of the intervention in terms of the population and the context. So if we think about the process of developing an intervention and to the process of implementing it, this is not really a linear process, and it requires quite a lot of back and forth going around before we actually get an intervention design that can actually be implemented. And usually we tend to think of them in terms of 3 phases. So you have the first formative phase, when we have studies which focus on trying to understand the context and the population, especially looking at current practices and behaviors and any other factors that are actually relevant for the intervention. And the second phase, you have the intervention development, and finally you have the evaluation. But again, as I said earlier, this is not a linear process, and usually the formative studies and the intervention development often starts simultaneously, because you start off with, say, key questions like, for example, if you think about the dietary intervention, it's just to think about how are food decisions made, or who is responsible for making food decisions. Or, for example, what is the potential role of a community in providing self-management support? So you have key questions you start with, and simultaneously start intervention development. But along the way, we often realize that maybe there are more questions that need to be answered, and that's more often the case than not. And you might go back and try to find more answers that are relevant for the continued development of the intervention. And as is often the case with this process, some answers come too late, because of course we have finite time in terms of project funding. So usually projects are funded maybe 3, 5, or 7 years, and depending on how much time we have to prioritize the questions that we want answered. So some answers, of course, only comes after the intervention has been developed and implemented, in which case it goes into the next cycle. So with implementation research, it's very common to see this plan, do, study, act cycle. So you have multiple cycles as the intervention and the implementation process is improved in each cycle. So going on to so I've divided this presentation into 3 parts, and the first part, I thought I would look at some of the knowledge that we have gained from the different formative and exploratory studies, and how that has been relevant for the interventions that were developed. So I think since we're talking about prevention, and it's good to start with risk and risk perception. So this figure is actually based on one of the studies that we did in Stockholm among participants who had been diagnosed as prediabetes in a study in the Stockholm Diabetes Prevention Program, which had 2 subsequent follow-ups at 10 years and 20 years. And these participants were actually met at the second follow-up. So they've had prediabetes for at least 10 years, and they have either reversed or they have progressed further. So it was to understand really how they understood risk. And I think some of the striking things were, of course, that risk is understood in completely different ways by different people. And it's also often difficult for healthcare providers to communicate risk. In fact, often the case is that healthcare providers feel that they have communicated risk adequately by you have told someone that they have prediabetes and that's it. But in reality, the person who has actually been given this information about risk doesn't understand it the same way as the provider does. So if we think about risk as a continuum, and with chronic diseases, we know that that exposures happen, of course, throughout the life course, and risk factors develop at some point which we are not really aware of. And this point when you are at risk is really a point when you may not even be aware of being at risk, but the point of diagnosis is really the hard stop, or the point when things change, because suddenly the condition has a name. You have doctor's appointments to look at maybe blood sugar levels, medicines to take. So suddenly there is a point when that information cannot really be ignored. And as I said, different people, respond to the information about risk in different ways. For some, being told that you are at a risk could just be enough motive to start making changes. But for someone else, it could be that, I don't have the disease yet, so nothing to worry. And even though this study was done in Stockholm, we've done similar studies in India where we've got we found similar observations, where risk is really seen as something not to be worried about yet. And that brings us to the next question, which is, okay, what is a healthy diet? And we asked this question to our participants in SMART2D in Uganda, and surprisingly, the answers, so they described healthy diet as nutritious, diet with good variation, and smaller portions. And if we think about the scientific, how we scientifically think about what's a healthy diet, these are actually, we talk about a nutritious diet, we talk about a balanced diet, we talk about dietary diversity, and we talk about small portions. So they've got actually that information spot on. And I think that is mostly true as well in terms of awareness, because usually the direction of awareness in a population is usually in the same direction as what science tells us, because there is a lot of mass media campaigns that are usually around, and people are aware of what is considered as healthy food. But as one participant pointed out, he pointed out exactly the reasons why you may know that it is healthy diet, but you're unable to really follow it. So for example, you may be poor, you may be sick, or maybe you don't know enough about the benefits. So usually it's in the details that you have lack of knowledge, and you also have other reasons or competing reasons whereby you're not able to actually do the things which you should do or you want to do. And if we think about what good food is, now good food is maybe a bit more broad, and the responses you get could really depend on who you ask. And we found quite a lot of similarities between the study that was done in India, and remember there's also a time span of about 7 years between these two studies, but there are still similarities. For example, when you talk to older participants, they often tell you about these modern foods which are not good for health, or that they really talk about traditional foods as being very healthy, and that younger people are kind of losing the good traditional foods. Then another aspect is about foods that the majority are not able to afford, like fish and meat, or other luxury foods, and also foods and behaviors which are seen as a sign of wealth. One example that I can easily think about is the behavior of eating out. So Kerala, about say 40 years back, 40 to 50 years back, the Gulf boom actually changed the I think foodscape in Kerala. And a lot of families in the state of Kerala, in many parts of India, but specifically from Kerala, you had a lot of skilled and unskilled labor migrating to the Middle East, and my parents included. So I grew up in the Middle East. It was actually so a lot of the Gulf style restaurants in Kerala was seen as an influence of the Gulf boom. So families returning back from the Middle East actually either started up restaurants, or there was a demand for similar restaurants, and you started seeing more of the Gulf style restaurants, and also this phenomenon of eating out, which was suddenly seen as desirable and, and good. So you can actually trace back some of the new behaviors. You can see how they have developed. And there are also foods which are often seen as having special benefits. So for example, again in India, we have a lot, and this is there in other countries as well. So you have these protein energy drinks, which are marketed quite a lot, of course, focused on children. So I remember one of the interviews that I did where a below poverty line family, a grandmother, she was actually telling us how she would borrow money if needed to actually buy the protein energy drink for her grandchildren because she felt that it was really good for them. So it's often because we also prioritize foods because we think that they have certain benefits and that they're actually worth the cost. And also we have behaviors of eating together, which is seen as a sign of kinship, which even in Uganda, it's changing now, where you see more this practice of having your own individual plates, which is seen as a sign of prosperity and wealth. So you see different reasons why certain foods are thought of as good or considered as special. One interesting observation was in Kerala, for example, we have a lot of different types of bananas. If anybody has been to Kerala or is from Kerala, so you have a lot of different types of bananas. And one of the interview participants, I remember him telling us that fruits other than bananas really belong to children. So, to children's diet. So if they, for example, buy apples or oranges, I mean, it's a given that they would give it to the kids in the family rather than have it themselves. And so that also next is to consider, like, what are the different parameters or different factors that go into food decisions. So in our qualitative studies in India, we actually found two main aspects that came out. One was about balancing different types of costs, predominantly financial costs. And that's, of course, understandable. So in this area where we did the study, it was a coastal area and a lot of the families were fisher folk. So when they had, during the fishing season, of course, they had, during the fishing season, of course, they would have fish to add to their diet, but otherwise it could be just rice and this a coconut chutney that I've shown in this picture. So this is a very specific chutney that's made in Kerala. So Kerala is the land of coconuts, which means that most families own one or two coconut trees. And it doesn't cost you anything to make coconut chutney. All you need is coconut scrapings and dried chili and salt and maybe tamarind, but that's about it. So you can actually have what they would consider a complete meal with just rice, coconut chutney, maybe dried fish, maybe fried fish, depending on what the season is. And as this interview participant also has talked about, I mean, how can you actually prioritize buying fruits and vegetables when you have to think about what else is it that you have to decrease? So this was a below poverty line family because they were talking about using rice from ration, which is a subsidy that is available. So that is available really at low cost. And then if they wanted, for example, buy vegetables, a small pack of vegetables costs about 30 rupees, which is actually less than $1. But with that, they cannot even make enough for the whole family. So then the question is, I mean, why do I do this? So I guess we all go through this negotiation process and in different ways when we make our food choices. And the second thing, apart from the cost, was about different types of preferences and priorities and taste. So the question is, who likes what? So it's not really about which food is tasty, it's really about who likes what. So if it is the spouse or the earning member of the family and the children have a higher priority or hierarchy in the house, and households and families do have unwritten hierarchies and power structures. As this participant in Uganda she was describing about how the husband gets the first or the preferred portion, and followed by the wife and the children. Now in Kerala, we found that it was the husband and children. I think you can probably toss a coin who comes up higher in the hierarchy, but it's either the husband or the children. And this woman who we probably talked to, she would place herself probably at the end of that line. So there are of course a lot of these unwritten rules and unwritten processes, I guess, that goes on within households. And these are negotiations. You don't do it explicitly, of course, but I mean, it is there, probably happening within all our heads. Illness in families, for example, is another priority. And again, that depends on who in the family has the illness. So for example, if we think about hypertension, where you need to reduce salt in your diet, I remember one of the families describing how it was actually the wife who had the illness, and what they would do is they would cook the whole food and they would actually remove a portion for her, so that the rest of the family can eat normal food while she has the diet regulated food. While on the other hand, we've also had descriptions of when you have the earning member who has an illness, it's quite common to see that the whole family has actually adapted or changed their diet around this person. Within families, of course, each family is individual. So I'm not trying to generalize here, but we do see some patterns, and there are always exceptions. And then we come to this. So in terms of developing the intervention, this question of who is actually ultimately responsible for food-related decisions is pretty critical, because the intervention has to be targeted at the person who's actually responsible if we want to see an effect. And in the Indian scenario, what we found was that the women were primarily responsible for food preparation, food procurement, and they were, of course, the ones who had an overview of the consumption habits of all the family members. But as they themselves would describe, they would purchase foods based on the preferences of their spouse or children and other family members. So even though they were primarily responsible, their responsibility was more by proxy, because they, of course, knew what were the likes and dislikes and priorities within their household. In Uganda, we had some descriptions of and this was also true for India, where men as decision makers, of course, have control over the sale of any produce, if it is cultivation, and household finances. And women would they would describe or talk very longingly of working women or urban women who they see as having more say in the food they buy, in the things that they can buy for their children, where they don't have to depend on the amount that they get from their spouse for their daily or their weekly expenses. So at least from our point of view, from the intervention point of view, what we decided was that since decisions were more or less at the household level, that the intervention had to be focused on the household. And while we would get the whole family on board, that we would actually be able to work with the women in the household in terms of the actual interventions. So it was a safe way out, because once the men or the decision makers in the house knew about the intervention, of course, they were willing to participate, they felt that their role was over. As they themselves would say, I mean, about food related matters or about children, I mean, talk to my wife, you know. And from the point of view of developing interventions, I think one thing that we often forget is that populations and contexts are not static. So populations are dynamic. There are changes in traditional ways of cooking. So there are changes from steaming to frying. You see emergence of new foods. For example, in Uganda, in the informal vendors, the tabletop vendors, they make this food called Rolex, which is actually a combination of chapati and omelette. And it's apparently very, very popular in both in urban and rural areas. And there are also new practices. And this was, I had never heard of this before, but about the use of paracetamol to reduce cooking time for meat and also preparation time for beans. So you have new practices that come. You also have changing perceptions of, of being fat or thin, or changing awareness and changing circumstances, for example, both internal and external migration. And one of the things, as I was mentioning earlier, the participants or the people that the target population that we work with, for them, the intervention that we are planning is not really their first priority. They have multiple realities and competing priorities, and we don't actually see them. We might be talking to or trying to work with someone who has who is maybe sick himself or herself, has a child who is in a critical condition, or an emergency in the family. So people do have other realities which our intervention competes with. And so the role when we develop interventions, it's to make it as easy as possible for participants to engage in the intervention, which, I mean, it's an easy thing to say that, but in reality, it's actually really difficult when you are planning and rolling out interventions to make it as less intrusive into people's lives as possible. And similarly, contexts are also dynamic, of course. So we talk about, the traditional food systems transition to mixed food systems. And these different types of food systems are, of course, a reflection of the types of outlets and, the promotions that we see. So you have a mix of formal and informal vendors, and this is what provides the opportunities for the target population, and this can change depending on the mix of formal and informal vendors. So this is a mapping that we did of outlets, of food outlets in Uganda, and the blue and the gray are the informal vendors, which actually there are a lot of informal vendors compared to the formal vendors. And what the informal vendors give a community is really the feeling of, one is that they're easily adaptable in terms of price, in terms of, convenience. You have smaller quantities, which you can actually purchase at your convenience. Maybe you can even pick things on credit. And that may not always be possible when you have more formal vendors. And these are also things that we consider in terms of the kind of opportunities that a target population have when we consider developing interventions. So I would like to go on to to talk a bit about strategies and tools, but Corinna, what about the time? Can you give me a heads up when it's time?
Yes, I can do that. Thanks.
Yeah. So to talk briefly about strategies and tools. So a friend and colleague of mine who is a behavioral scientist working with translation of interventions across different contexts, she usually uses this because she says the content is very important, but the content is not about the context, because the context finally defines what is actually possible in a setting. And that's a good take-home message to remember, and we are reminded of this every time we actually develop and implement an intervention. And a context is of course multi-layered, so you have multiple layers which are always not relevant for all interventions. So depending on the intervention that you're working with, maybe the inner setting is maybe only a household, and the outer setting may be just the community. So the context actually changes also depending on the kind of intervention that we are trying to design. But with all this information that we collect in the formative research, how do we actually try to incorporate that so that it actually fits the context? So usually what we do is we use theories when we try to design an intervention. And in the Kerala study, this is the conceptual model that we used. Usually most of the planning models like the intervention mapping protocol or the MRC guidance for complex interventions, they actually give you there is a step-by-step process on how to develop interventions. And one of the steps is usually about the theoretical concept, or what about the theory in terms of what you want to achieve. And we used actually 3 health behavior theories: the health belief model, the theory of planned behavior, and stages of change. And what we did was, based on the interviews and focus group discussions that we did in India, we actually mapped that, or we used framework analysis to kind of match it between the theory and the actual data. And we came up with these different colors. So the green blocks are actually the constructs, the theoretical constructs, which were taken as such from theories, as defined by the theories. The blue ones are theoretical concepts inspired by the theories, but modified to fit the context. And finally, you have the ones outside, which don't really come into these 3 theories, but we felt was really important to include them. And these were, I mean, all of these different constructs, each of those hexagons were finally translated into the intervention in one manner or the other. So I'll just give you one example of how we use the stages of change. So we use the stages of change model to actually do a grouping process to understand what is the common denominator. And the original model has about 5 stages. And when you want to stage an individual, it's actually quite easy to see these 5 stages. But at a household level, when you want to stage groups, that's not so simple, not as simple. So based on our formative studies, we actually modified this into 3 stages. So the pre-contemplators, we kept them as such because they are the group that's actually not really ready. Then you have the contemplators, which we combined the original stages 2 and 3. And finally, you have the ones in the action stage, which is again a combination of action and maintenance. And we actually found that this was a good grouping. And based on this, we actually developed stage matched strategies. So for example, pre-contemplation, the ones that are not ready, they just receive invitations to attend awareness sessions, which were free and open in the communities. So these were the awareness sessions for adults, information booklets, and card games for children. And for contemplators, we prepared a kit together with a few other strategies, but this kit had actually a few locally available measures. One was a fruit basket, just to basically keep fruits visible and easily accessible, because even from snacking behavior, we know that, I mean, we eat more of what we see more often. So use the same principle with fruits. And then we had local measures for measuring, like 1 serving of cooked vegetables, or even to measure oil. For example, how much of like oil do you use in a month, or how much of oil can you use for cooking in a day in a household. And finally, for action, which is the last or the most advanced stage, you had more difficult strategies like like working with or using locally available fruits and especially vegetables, which had previously been used but not so common anymore, or budget reallocation, because budget is a tough thing to touch. And unless you're really committed, it's difficult to consider which are the items in our budget that we could actually think about reducing or considering keeping aside for maybe to use for purchasing of fruits and vegetables. So we had done the stage matching of different strategies when we implement, and this is what we implemented. Now in the SMART2D intervention, we of course had facility and community strategies, but I'll just focus on the community strategies. And we, all three sites agreed that we had these three core components, which is the peer support component, the care companion component, and the link between community and facility. And here, I just talk mainly about the Swedish experience, where the peer support component was actually implemented as individual telephone facilitated health coaching sessions. And as you can see, each of the different settings implemented these three components differently. So the idea was to standardize by function and not to standardize by content. So the focus of the SMART2D intervention was on self-management. So even though we did have a conceptual model, the SMART2D framework, but the backbone of that framework was really self-determination theory, because of how important it is for self-management. And here the grouping was based on disease status. So we had either pre-diabetes or high risk, and we had type 2 diabetes. And this is the intervention program on especially the facilitated health coaching sessions on the Swedish side. We had the Healthy Buddy program, and they had these 9 sessions with physical activity and diet kind of alternate sessions. And the main message, of course, being small changes can make a big difference. So, that was the similar message that we had actually also in the Indian intervention. And here, before we went in, of course, in Stockholm, this intervention was done in socioeconomically disadvantaged suburbs with high proportion of immigrants. And these are actually, there's a term that's used to describe these many of these areas, which is super diversity or super diverse communities, because it's a small geographic areas but have large diversity in terms of language, ethnicity, age, socioeconomic status. And in some of these areas with maybe 20 to 30,000 population, we are still talking about 100 plus nationalities living in the same area. So we were already aware of the need for different language competencies, and that is something that we were able to provide with the intervention, because we had facilitators, both normal Swedish, easy Swedish, and then Arabic, Somali, Spanish, English. So we had a few different language variations. And if they were able to understand in easy Swedish, that was always an alternative that we could use. But the other thing that we did not and could not do, because this was also a feasibility trial in Sweden, we implemented a feasibility trial, and that was that participants, of course, had different starting points. So you can have participants who are very advanced, so they were already physically active, maybe more than 10,000 steps every day, and working with diet already in their daily lives. And you also had participants who are at the other end of the spectrum with less than 2,000 steps daily, or and food habits being not so healthy. So this different extremes require some kind of grouping in terms of strategy. So what we should have had was different strategies addressing people at different starting points. So for that purpose, we would have needed a tool to actually group participants into different different groups for the different strategies to work. And that was not something that we did in this intervention. But if we get funding, that's one of the things on the agenda. And also go bit briefly to talk about two examples, one on gamification and on estimates, to talk a little bit about what happens when we translate our scientific knowledge into actual practical information. So two games that we prepared for children, these were card games. They were made really like playing cards. They really the same size as playing cards. And we had two games. One was about plus and minus foods, to really talk about the concept of healthy versus unhealthy foods, what makes foods healthy, what makes foods unhealthy, and these different points that you see were actually based on different kinds of principles. So fruits and vegetables versus snack items, or fried items versus steamed items, local items versus exotic items. So there were a few principles that we used. And the aim is, of course, to see if they, depending on the cards they choose, what kind of an overall score they would get. But the ultimate aim about their understanding what is healthy versus unhealthy is also for them to understand that, okay, if I want to have a healthy diet, it does not mean that I have to give up all my favorite foods. So that was something also that we built into the game. And the second game was about looking at the colors of fruits and vegetables and how they benefit different organ systems. So here again, I mean, we used the evidence which is based on different literature about how different colored vegetables, how they are beneficial to different organ systems. And depending on that, the end result is to help the children understand that you need different colors of fruits and vegetables. You need a diversity to be able to benefit different organ systems, and also that you don't need to have them have all 5 colors every day. For example, that's not the objective. But that if you say have about 3, we know that there are about 3 combinations of colors which actually can benefit all the different organ systems. And every time parents go shopping, it's about telling them to get something new, get something different, so that we are not buying the same vegetables or fruits every time we go shopping. And also, and this is an example of how we did an estimation on for cooking oil or cooking fats, I would say. So we actually developed, we had a local measure, a cup, where we had put a level saying this is like the maximum level of cooking fats that should be used in a day for a family, depending on their on the number of members they had in their family. And how we came to this estimation was, we used, of course, the national recommendations based on the Indian Council of Medical Research guidelines and the National Institute of Nutrition. And so this fats should be approximately equal to about 30% of total daily energy intake. We use that together with other contextual information. For example, we already knew that the majority of the fat, the source of fats was from both the invisible fats in foods, and the other was from cooking in this setting. So processed the foods was not that commonly used. And we also know that the types of fats, coconut oil was one of the most common mediums that were used. There were a few others, but that was really the most common. And also special practices in the fact that, I mean, coconut scrapings, which is coconut meat, coconut water, and oil, these are all products that could be used for cooking. And we had to actually adjust our final estimations based on all of these factors. And these estimations were done for a reference family. So what happens with these kind of estimations is, of course, that even if you think about the card game or this estimation, is that it does not accurately fit every single participant. But at the same time, it is a general good fit with the practices of that target population within that setting. And since I work with interventions, it's I mean, we try our best to work as accurately with science, with the evidence as possible. But often we do have to approximate and bring them down to a more practical level so that the information is actually useful in our daily lives. And with that, I will come to the last bit of this presentation, where talk a bit about the process and outcomes. And I think when we talk about the process or the interventions, we talk about sustainability, and I guess two types of sustainability. One is the sustainability of the intervention versus the sustainability of the outcomes. And the Chambers et al. In their paper on dynamic sustainability framework, they talk about these two concepts of voltage drop and program drift, which is very common in real world interventions. So voltage drop is something that happens when you go from efficacy to real world interventions, because I mean, we're just adding, as we go from left to right, we're just adding so many more variables. So the benefits, of course, drop as we go from efficacy to real world interventions. And then you have program drift, where, I mean, when we develop an intervention, we of course have this beautiful protocol where, you know, we have outlined everything. And then we go to the field and implement it, and we realize that things don't work as we thought or as we planned. And that is also something that we very commonly see with real world interventions. So for example, the SMART2D intervention, initially, the peer support component for Sweden was also considered to be a group format, similar to what was possible and very commonly seen in the Ugandan and the South African setting. But we actually piloted the group format twice in the Swedish setting, and we realized it just did not work. The structure of the communities and the way they interact and how the health system is structured is also quite different. So what happens is when we schedule these meetings, it's not the same people who come for subsequent meetings. And the facilitator ended up having to kind of do intro meetings every time just to get the participants on board. And it was just not feasible to continue. So we used the same format and modified that into a telephone facilitated format, and which was what was finally implemented in the feasibility trial. So when I think about developing interventions and this question about the different components that go into it, maybe it could be good to think about how builders and architects have different model houses, and usually you have these different models where they have already thought about the base ingredients, let's say, that go into it, the basic kind of structures, the basic products that they would use, and they have a pricing for it. And some people, and of course what happens when you have a frame is, of course, that there will be some exclusions, like we saw in the Indian study, where we could not have subsidies as one of our intervention strategies, so we had to exclude below poverty line families for ethical reasons. And you can also have mismatches. So for example, the house just may not suit everybody. And we had that with for example, in the Swedish intervention, where we saw that we had developed the 9 sessions, keeping like an average target population in mind. So it actually worked for all of them except for the more advanced users, for whom we actually needed more or different strategies, and we did not. And I guess the other thing with having a frame is also that the frame can have core elements, and the frame also has opportunities for personalized elements. So for an intervention sustainability, I think personalization is really a key factor, because even though we're talking about population interventions, every individual in that intervention needs to feel that this intervention is actually for me. So there has to be an opportunity for personalized elements. And that's also important when we think about institutionalizing behaviors. So it's similar, it's about small changes or changes that we can actually incorporate into our everyday lives, and strategies which are easier to help institutionalized behaviors are more likely to be sustained. So that's, I mean, these are some of the things that I guess that we realize or understand every time. And of course, sometimes we are reminded of them at the end of an intervention when we realize, oh, that didn't actually work. So that also happens. And this is in brief some of the outcomes of interest with the Kerala study. And as you can actually see here, at the end of a 1-year intervention, the fruit and vegetable intake and fruit procurement, actually there was not much difference between the intervention and control arm. There was no significant difference. But where we saw the difference, it was really in vegetable procurement and reduction in salt, sugar, and oil consumption. So these were huge and significant changes from baseline to end line. But we can think a bit about why we actually didn't. So we saw an increase in vegetable procurement, but we didn't see an increase in vegetable intake. So when we dug into the data, we actually saw an interaction, gender and socioeconomic status interaction. So among the lower middle, so the socioeconomic status, we had 2 groups. We had low middle and high middle expenditure groups. So in the low middle expenditure groups, the male participants had higher vegetable intake, and gender was also found to be an independent predictor of vegetable intake when we did our regression analysis. So clearly there is something there, but at the same time, we can also think about how the study was designed. For one thing, we had more female participants than male participants. That was not by design. That's usually what happens with community-based interventions. And we also found that we had to make a lot of effort to actually recruit the male participants. And the other thing was about how we actually measured intake. So procurement was measured at the household level. Intake was measured for one selected individual in each household, and that was done randomly. So which means that, I mean, in retrospect or hindsight, when we probably should have measured intake in all the members of the recruited family households, then we would have actually seen, okay, vegetable procurement increased. Where do we see an increase in intake? But like I said, that's a reflection in hindsight. And the other thing is, of course, that we had some temporal trends. So we did have changes in the context. There was the National Program for Control of Cancer, Cardiovascular Diseases, and Stroke was actually implemented around that period. So there were a lot of mass media campaigns which affected both intervention and control areas equally. There was also an inflation around the time of our actually a huge inflation around the time of our end-line evaluation. The prices of fruits and vegetables kind of, increased drastically, and that would have also had an impact. Because one of the things we saw with vegetable intake, and also not with vegetable intake, with vegetable procurement, was that those who had used locally available procured vegetables, they actually were able to show a higher household procurement of vegetables. So some of the intervention strategies, of course, worked, but it was also the fact that there were trends within the context that we couldn't really control. And in the SMART2D intervention, our primary outcomes are not really related to diet. So they were about diabetes. So what we actually saw with type 2 diabetes was that there was the community component, there was actually no difference if you had an adequate or well-functioning facility care. And the added benefit for the community component that we saw was really for high-risk detection in Sweden. And we also have seen some benefits for type 2 diabetes prevention, which is for pre-diabetes and high risk, though that was not seen in unadjusted analysis. And we are actually now this project ended actually only in March. So we are now doing our secondary analysis, and it would be actually interesting to see, especially with self-determination theory and how that relates to healthy eating in the different contexts. We have already looked at that from the baseline data, but what would be interesting to see is how the intervention actually influenced some of the intermediate outputs that we want to look at, especially related to the theory. So that is yet to come. So I think that kind of brings me to the end of this presentation, and I would like to leave you with this slide. Maybe not no intervention, but I think most interventions don't survive the first contact with the context intact. I mean, some parts of it do and some parts don't. And that's also the reason why different study cycles are really important, so that an intervention is modified and tested and modified and tested in different cycles. So I think that brings me to the end. I would like to thank all of you for your attention and acknowledge my colleagues in both the projects and other, the research staff and participants of the different projects, and also the funders. Thank you very much.
Thank you very much, Meena. A lot in that presentation, and we have some questions here that are asking some quite detailed questions to you, which I will ask. I do have one question, which is a request. Florence is requesting, could you show the slide again with the honeycomb coloured element, please?
Okay.
There isn't any question, but presumably she wants to ask a question once you show it again. So if you wouldn't mind sharing your screen, if you're still able to do that, and showing the slide.
Yeah,
with
I think I can. Just a minute.
The honeycomb coloured element, she says.
Okay, can you see the slide?
Yeah, we can see the slide, yeah.
This one.
I assume that is the correct one, but Florence, perhaps you can just confirm in the Q&A that that's the correct one. Oh, okay, no, she just wants to see it again.
Okay.
Found it very useful and wanted to look at it again. So.
Yeah, but she can find information about this in that particular paper, not this honeycomb figure, but about how we actually use these different constructs.
Great. Well, I'll start with some of the more detailed questions, and then we've got some broader questions as well. I'll start again with one of the latter things that you spoke about, which is a request from Madiha for a clarification about the difference between vegetable intake and vegetable procurement. Was it that your analysis showed that households were buying more vegetables but not necessarily eating them?
Yeah, so thank you for that question. That was an important one. We actually had collected information on vegetable intake, which using a 24-hour recall, or rather 3 24-hour recalls, which were then combined together. And for the vegetable procurement, we actually had a diary which the households kept for 2-week period, where they actually recorded everything that they procured. And this included both foods that they purchased and foods that they procured from their surroundings, maybe their own backyard. So we gave them the option of writing either in terms of rupees, like, so that we have an idea of how much they actually purchased, or in terms of weight. And when we did the analysis, we actually used the consumer index, where they publish all the prices of the fruits and vegetables. We use that to estimate the weights if it was written in rupees, and we basically combined all the procurement for a family for 2 weeks. So does that answer your question?
But why was this, Meena?
Yeah, so I mean, it was, so the reason to understand, I mean, when you think about household behaviors. One is to think not just about the intake, because the intake is really the end of the equation, isn't it? There are a lot of things that actually happen before, where you think about from the decision to the procuring to preparing and finally consuming. So the procurement was found to be an important middle step to see, I mean, is it that people are actually not procuring enough fruits and vegetables, that which is not actually getting converted to intake, or I mean, what is it? And I think one of the things we actually already saw, that okay, you might actually have an increased procurement, but it does not translate to increased intake for all members of the family. And in hindsight, as I said, that was a I mean, we should have actually collected intake for all the family members. Then we would have clearly seen where the intakes increased. But I think we have a good guess about it, because in the formative studies, we know that the women prioritize the needs of their spouse and children. And our hypothesis is that yes, food procurement increased, and food intake also increased, fruit and vegetable intake also increased, but primarily for the spouse and the children. And the women themselves put themselves at the end, and we did not really address that in our intervention. We didn't do that.
So it's an even, I guess it's requiring an even closer and more detailed analysis, looking at different populations within the household. Another question here is that you've talked about the combination of colours of fruits and vegetables used in these interventions. Did you find, Emma's got a question here, did you find any combination of colours as particularly beneficial?
Yeah, actually, that's very interesting. So there are actually 5 groups of colors. So you have orange and yellow, which are together, which is the same group. Then you have green, then you have red, blue, and purple, which is again together. And then you have white, tan, and brown, which again have the same properties. So you actually need only 3 groups of colors to cover 10 or all the 10 organ systems. So if you have, for example, either orange, yellow / green, and you have one from the red and blue group, and you have tan. So tan is important, or tan or white is important, but the others you can actually mix and match between orange or green or red and blue, and you actually cover all the different organ systems. The white or tan group is actually beneficial for the immune system and the endocrine system, so, and that's very special. So
thank you. And another question about the stages of change from Emily, and she's saying, looking at the stages of change and the 3 levels, what was the proportion of pre-contemplators, contemplators, actors, and how did this distribution between these stages of change impact on the delivery and reach of the intervention?
Yeah, I'm just trying to find those numbers. So yeah, when we actually started, so we started the intervention, we had 3 different time points, 0, 6 months, and 12 months, and we staged them at 0 and 6 months, and also 12 months to understand the end stage. So when we started, we actually had, if I remember right, it was more contemplated. We had the least in the action stage and more in the other 2. And finally, at the end stage, we had the majority of the households in actually the action stage. But I think what we have to remember is these stages of change only signify a readiness to change behavior. It does not signify an actual change in behavior. So my hypothesis is that the readiness to change, of course, comes much before, and it's the mental process happens before the actual change happens. Yeah.
Great, thank you. Thanks for that. A question here which builds off the point that you've made about women. We talked about the measurement in the household and the role of women, and a question from Paulina here, who has lots and lots of questions, but I'll pick this one for the moment. Something I'm rather curious about is how can these deeper social issues about the role of gender in this case in society, and how that plays out at the household level, how can the intervention address these issues, which are essentially about gender stereotypes at the home, and might well have a really important impact on the ability of the intervention to have impact on certain household members?
That's a very good question, and I have to say a very difficult one to answer, because we are talking about interventions that maybe run, I mean, in this case, it was an intervention that ran 1 year, and maybe we took another 1.5 years in the initial formative phase to understand this. So what I would say is that from an intervention development perspective, it's very important to understand this reality. And for example, in many of our households, I think we would not have been able to recruit these households if we didn't understand this reality. It's not ideal, and a 1-year intervention is very unlikely to bring about a drastic change in the status of women, but it does a little towards promoting their role within, with provision of healthy food in families. And I guess one of the realities that we of course had to face is we needed to get the men in the household on board for this intervention to work, because in the formative phase, it was we had some of our participants actually telling us accounts like, I mean, I know that salt is not good, or we use too much of spices in our food, but my husband likes spicy, salty food, and if I don't make it, he will probably just dump the food. So we do have accounts like that, and this was something that we had to actually be very careful about. So we got permissions from the whole families, made sure that the men in the family were on board with us. But after that, in terms of the intervention strategies, we actually worked mostly with women. I mean, that was from an intervention point of view, I think that was the most practical thing we could have done.
Thank you. Indeed, a tough one, and fascinating to hear about your insights gained from the actual research process itself. Salah's got a question here, praising your slides and fascinated by what you've said about context, and the fact that context changes as well, and you made some points about the changing a broader context. But how do you build into the fact that there is this temporal change as well as other differences in context? Does it mean that you come back and at the end, I think she posted this question before, you talked at the end about the impact of your interventions, but does it mean that you come back and revisit the interventions to see if the effect may have changed over time? And how do you take account of the fact that these contexts change over time in your work?
Yeah, thank you for that question. I think that's again a very interesting question, and a very difficult one as well. In this dynamic sustainability framework, actually, the authors really talk about the intervention being relevant in time t0 and time tn, as time progresses. I think in reality, this, at least from my experience, and which is pretty limited, if we think about this interventions with core components and then these personalizable elements, I think the intervention needs to have some room for actual change. So that all the components in the intervention are not really fixed from the beginning. So if the components of an intervention are completely fixed, there's really no room for change, and that will work in that time period, but not in the next. And when interventions work with the strength model, as we have done in the SMART2D, where you actually build on how people currently practice, or their different types of food behaviors, then you actually leave room for the participants themselves to modify and add on. So I mean, the intervention serves its purpose if you have helped participants to see that they can actually start off and make further changes themselves. And I guess that is really the key, that we don't really fix all the parts of an intervention, that we leave it dynamic, that it can change over time. And again, that's easier said than done.
Interesting. I've got a couple of questions now on the data gathering processes themselves. Charlotte asks about the fact that in Sweden, you mentioned that you'd adjusted the intervention, so it was on a one-to-one rather than a group format. And she asks if you could share your thoughts on the positives and negatives of individual versus group-based interventions, particularly in the context of NCD and data interventions that you work in mainly.
So I think the answer is really depends on the target population and the context. I think one of the assumptions that we made when we developed this, the SMART2D intervention, was, of course, we had done our formative research. So when we developed these three components, and for the peer support component, we developed the group intervention, we assumed that that is going to work in Sweden, simply because, the areas that we chose were immigrant dense, and a lot of families from sub-Saharan Africa, from Middle East, who have this history of, who have come from communities where it's so common to have these kind of group approaches. But as we saw, that was not really the case. And in terms of, for the Swedish side, at least, it was really the one-to-one facilitated intervention that actually worked. I think the peer support model, where you needed the same participants to come back consistently for different sessions, would not have worked. And we tried that in, like I said, in 2 different pilot studies. So we had to give that idea up and modify that into this telephone facilitated session. So each one has its strengths. So the telephone facilitated session definitely had strength for this group, because they could develop some kind of a more personal relationship with the facilitators. It was more or less the same facilitators who met, who talked them through the 9 different sessions. And we did a study on how acceptable the participants found this intervention, and most of the components were actually found to be acceptable. The one where they showed some variation was in terms of perceived burden. So participants who were high risk actually felt higher burden to do the different activities than participants who had type 2 diabetes. And our hypothesis is that those who had type 2 diabetes were already probably in the mode of having to do different things to take care of their disease, while those who were high risk, they're new to actually thinking about themselves as needing special strategies to take care of their health. So they, of course, perceive a higher burden than people who are already in the cycle, in the care cycle. At least that's our hypothesis on that.
Thank you. And then another one from Alex about the data gathering processes, but this much more about the food intake measurements. Of course, dietary assessment is always a very tricky area. But were there any other data gathering techniques you considered for measuring food intake, such as food diaries, pictures of meals, apps, etc.? The dietary recall.
So for the Indian study, we actually used the dietary recall method, because the food frequency questionnaires would have been extremely tricky, considering the wide variety of foods and ingredients that go into the different foods. So actually we found that the dietary recall, and we used a multiple pass method, and we also had a food map to actually help them remember the different occasions. And from that, it was not that difficult to actually tease out the fruit and vegetable intake. So I think for that setting, that was probably I still think that was the best method. And we used, of course, different types of measurement, like serving spoons as measures, as reference for the participants. The data collectors were trained in taking with them different serving spoons when they asked them about different types of vegetables, and we knew what the local practice was, what kind of serving spoons were used for curries versus other dishes, and we used those different kinds of serving spoons as reference point for the data collection.
Thank you. Great, and a question that has been waiting for a while from Mark and Peter. Two people asked this question. It's a question I was going to ask too, which is you made it very clear that your work is about informing interventions, and my experience, you can often take this work which is focused on interventions and understand what it might mean actually from a policy perspective, given that public policy is used also to encourage different diets in different places around the world. So would you say that there's a key lesson for policymakers from your testing of interventions? What are the policy implications? What could you tell policymakers about how to design their policies better based on the work that you've done?
Well, I think one of the things that is similar with policy as well as with interventions is about how you translate evidence to usable practical knowledge, like for example either the card games or the different types of serving spoons, or it's still about taking evidence which is maybe numbers and jargon which not everybody understands, to something that is really useful for us in our daily life. And that is also true for policymakers. So if we think about different strategies like the green keyhole or the traffic lighting system, they're probably more widely useful than a lot of printed information on food products, for example. So the easier it is for people to understand and assimilate and use the information, the more likely that they're going to use it. I think that is one. But there is also a key difference between policy and these kind of interventions, in that these interventions, of course, work very closely with different participants, while policy has a much more overarching effect, in the sense that you're not recruited into a study for the policy. The policy is there in place, and you as an individual, there are some things like a tax on a food product. You have to pay it whether you like it or not, but you can choose whether to buy a certain product or not. And I think that is different when you think about the health interventions that I talked about versus policy interventions. But of course, there are lessons for both, especially in terms of whether it fits the context and the population, for sure.
Thank you. It's a really good answer. A point about another question from Pasi here about whether you've actually done any studies that have included looking at promotional claims that are made on food. Is that something that you've looked at?
Well, we as part of our mapping exercise, we have actually looked at in Sweden, South Africa, and Uganda on food products that we have identified in different stores. So we've used an EPOC tool and done a mapping exercise. So we've looked at health claims in that respect. But I really can't tell you much more about that, because we haven't worked so much more with that. One thing that we do see, for example, in terms of promotions, we do see a difference in terms of product promotions versus kind of health promotions, which are a proxy for product promotions. In the sense that in more well-regulated markets, you see more of the health promotions, whereas in less regulated markets, you see less of the more of the product promotion. So that kind of difference you do see, and health claims are also so tightly regulated. So you would see that more and more regulated markets, I would think. But no, we haven't looked so closely at it.
Thanks to you for answering that question. I'd like to, I'll bring this to a close now. There were a great lot of questions. I'm sorry I wasn't able to get to every single one of them. But thanks very much for such an engaged audience with such questions, paying attention to the detail and the richness of what you were conveying. And I think there's a lot of lessons there for process about intervention design, as well as practice of intervention design. And I certainly was taking notes about the implications for policymakers, and was fascinated by your answer to that question in particular. So thank you very much indeed, Meena. That was a really great presentation. And thank you very much. Yet another view on a different perspective on how we can become more effective in changing food and changing food system from a really smart thinker. So thank you very much, Meena, and thank you very much for our audience for being so engaged this evening. And whatever time it is in your day, have a nice rest of the day. And I'll thank everyone for joining us, and please do join us on October 21st for our next in our series. Thank you, everyone.
Yep, thank you very much.